Thank you very much. Thanks for attending the course and for the invitation to speak. As was mentioned, I want to talk this morning about immunotherapy. And then as we start to expand the indications for immunotherapy and try to maximize benefit for our patients, I think it's useful to talk about a framework that I like to call the tumor immune ecosystem, which I'll explain in more detail. And this really gets us thinking about how we can incorporate other treatments like radiation or other targeted therapies, and particularly SBRT, to maximize effectiveness. So here are my disclosures. I will discuss some investigational uses of immune therapy. And what I hope to do is to start, for anybody who's not an immunologist, make sure everybody's on the same page, talk a little bit about the history of immunotherapy, because I think that helps put things into context, and also provide some working immunology background, which I think is helpful at this point for radiation oncologists. And then talk about, despite the great successes of immunotherapy to date, there's a number of significant limitations. And when we start to think about how we might overcome some of these limitations, we can see a role for radiation here. At that point, we'll have some discussion and then move on and talk about some of the clinical data, focusing on some of the more practical aspects of combining radiation immunotherapy, questions regarding safety, dose, fractionation questions, and then look at some of the evidence about clinical benefit, and then what I think is a very helpful avenue of research in the future will be looking at biomarkers for the combination of radiation and immune therapy. So I think this is probably very well known by everybody at this point, and that's just how much cancer immunotherapy has and is changing the field of oncology. Just a few weeks ago, the Nobel Prize in Medicine this year was awarded to Drs. Allison and Hanjo for their contributions in developing modern immune therapy, and specifically looking at immune checkpoint blockade. And immunotherapy, despite these recent successes, really dates back much further than this. So actually, some of the first immunotherapies were tried in the early 1900s. So in New York, there was a surgeon by the name of Dr. Cooley, who noticed in some of his patients, some of his advanced cancer patients, that when they had infections, they could sometimes see spontaneous regressions of their cancers. And so he thought that something was going on immunologically, and he actually tried to take advantage of this therapeutically by taking some of these infectious materials and injecting them back into his advanced cancer patients. This was one of the first cancer patients that he treated on the right. This is a patient with a head and neck sarcoma, a laborer in New York City by the name of Zola, who received these infectious particles, what came to be known as Cooley's toxins, and actually had an impressive response and survived for far longer than would have been expected at the time. Not surprisingly, despite some of these successes, Cooley's toxins was a pretty crude answer to early immunotherapy. And so a number of patients that were treated with these infectious materials developed sepsis or severe infections. And the response was unpredictable and rare. And really, these early, if you look at the early history of cancer immune therapy, there was the hypothesis that the immune system could identify cancers, just like it could identify infections, and eradicate cancers in some circumstances. But this idea was limited by really the lack of a sophisticated understanding of how the immune system worked. It was thought that the cancers could somehow suppress the immune system from recognizing and eradicating the cancer cells, but it was unknown how the mechanisms by which this worked. And really it took about a century of detailed immunological investigation to gain an increased understanding of T-cell biology. And it's this increased T-cell biology that really paved the way for the more modern types of immunotherapy. And specifically, I'll talk about this in regard to immune checkpoint blockade. So again, apologize if this is already known by some people, but the increased understanding of the immune system included an appreciation of the major players. And if you look at the immune system, you can divide it into two general categories. So on the bottom, you have the innate immune system. So the innate immune system includes cells that derive from a myeloid stem cell. And this precursor differentiates into the red blood cell, the erythrocytes in the body, also into the megakaryocytes, which develop into platelets that aid in blood clotting, and also two other cell types, so monocytes, which in cells in tissues of the body further differentiate into macrophages, and then granulocyte, which include, among other cell types, neutrophils. And what's important about this innate immune system is it's the body's rapid line of defense. It's relatively nonspecific. It responds to patterns that are largely indicative of bacterial and viral infections or other sites of inflammation. But it also is the first step in the generation of the part of the immune system that's shown on top, and that's the adaptive immune system. And the adaptive immune system, of course, is the more specific and longer-lived type of immune response that our body generates in response to infection and other threats. The adaptive immune system really derives from cells that come from a lymphoid stem cell. And in the thymus, these lymphoid stem cells differentiate into T lymphocytes, which I'll talk more about shortly, and also into other cells that are relevant for adaptive immunity, including NK, or natural killer lymphocytes, and B lymphocytes, which further differentiate in the bone marrow to plasma cells that can produce antibodies that aid in adaptive immunity. So the T cells are really our army in the battle against cellular infections and also in cancer. And T cells can recognize and attack cancer cell. You can see this schematically on the slide. The immunologic T cells attacking a cancer cell here. And how does that work? So T cells on their surface start out or T cells start out as naive T cells. And because of mutation and recombination, these naive T cells express pretty much an infinite number of T cell receptors on their surface. So you can see they all look a little bit different. And they recognize foreign materials or materials that are different from the normal proteins of the body called antigens. And these antigens, for each antigen, can bind specifically to one specific or a few specific types of T cell receptors. And you need that specificity for the T cells to become activated and differentiate. And so when you get binding of this antigen, this dangerous particle, you get what's called clonal expansion of your T cells, shown in blue, and then further steps cause the differentiation to effector T cells, which can then kill infected or cancerous tumor cells. But you can imagine this is not enough, because if you just had a kind of limitless pool of T cell receptors that can recognize these antigens, you wouldn't just recognize infected cells or cells that were infected with viruses or cancer cells, but pretty much any tissue of the body that expresses any protein or anything that we ingest or inhale would be fair game to be recognized and targeted by the immune system. So the immune system is more complex, and it's developed a more complex system to guide T cell activation. So if you see the T cell schematically shown on the slide in blue, you have what's the T cell receptor, or TCR, and then you have these other receptors, or co-stimulatory receptors, one example of which is CD28. And CD28 and these other co-stimulatory receptors, they're designed to detect danger. And so you don't want your immune system to become active against just any foreign particle or molecule or foreign antigen. You want it to specifically become active in the case of threats. And so you can imagine a few different scenarios. So if you take the scenario on the far left, you have an APC, or antigen presenting cell, shown in green. And if the antigen presenting cell just expresses a danger molecule, one example of this danger molecule is called CD80 or B7-1, and that combined to CD28, the T cell knows that there's danger, but it doesn't have this specificity signal or second signal. It doesn't know what to become activated against specifically. So not surprisingly, it doesn't become activated and you don't see any effect. Conversely, if you have a tissue cell in the body that, shown in pink, that expresses a tumor antigen, and the tumor antigen is generally presented on a molecule called an MHC, or major histocompatibility complex molecule, this can then specifically bind to a T cell receptor but you don't have that second danger signal. And so you can imagine this is the scenario that might happen most frequently in the body with all the antigens that we ingest or inhale. There's no threat here. You don't want your immune system to become activated. So not only do you not have an effect, the T cell doesn't become activated, doesn't clonally expand, but actually the opposite can happen. This T cell can become less likely to respond to future stimuli, something called anergy. Only when you have the two signals working together, shown on the far right. So you have this tumor antigen that's bound in the context of an MHC molecule, and then you also have this secondary danger signal such as CD80. These two can be expressed or exposed on the surface of a dendritic cell, which is one type of these antigen-presenting cells. Then the T cell in blue sees these two signals, and when you have these two signals, you get this activation and differentiation. And then in the case of a tumor, you can get an anti-tumor immune response. So, not surprisingly, it's actually more complicated than that. So you don't just have these two signals, but there's a number of signals that have been identified as T cell biology has been uncovered, especially over the recent decades. And so the work that has been done, including the work that led to the recent Nobel Prize in Medicine, really helped identify some of these intricate regulatory systems that T cell use to regulate their activation and inhibition. And among what's been identified is a number of activating receptors on a T cell. So I showed CD28 in the previous slides as one of these activating receptors. There's actually a whole host of activating receptors. And you can think of these activating receptors on a T cell, they've been compared to the accelerator or the gas pedal. So they respond to danger signals, they ramp up immune activation, and they're overactive in the cases of autoimmunity, so in patients that develop autoimmune disease, or in cases of inflammation, these activating receptors become increasingly activated. On the other hand, you have these inhibitory receptors shown on the right of the T cell in yellow and orange and red. And these are what are otherwise known as immune checkpoints. So it makes sense that your body has developed these brakes on the immune system as well, because you don't want your T cells to become overly active and lead to autoimmunity and cause death of normal tissues of the body. So you can think of these as the brakes in the immune system. But these brakes can be exploited, and so they're exploited in a pathological manner in cases of immunodeficiency. And then what's also been discovered, and what has made cancer immunotherapy or immune checkpoint blockade so successful, is that cancer cells can also exploit these immune checkpoint receptors and prevent anti-tumor immune responses. So I wanted to focus in specifically on the two inhibitory receptors that are present on the surface of the T cell that led to the Nobel Prize and that have been used most frequently in the treatment of solid tumors, and that's the CTLA-4 and PD-1 inhibitory immune checkpoints, inhibitory receptors. And so what's been discovered in multiple different tumor types, what was discovered first in the case of chronic infections, is that cancer can exploit these immune checkpoints. So you imagine you have your T cell, it can recognize the cancer cell, it can recognize something that's different about the cancer cell than the normal cells of the body, some mutated tumor antigen, for example, and that tumor antigen is presented by the tumor cell and is about to stimulate the T cell receptor, and then you might get T cell killing. But at the same time, this tumor cell, through a variety of mechanisms, is able to activate the inhibitory PD-1 receptor on the surface of T cell. So you get expression of, for example, one of the major ligands of the PD-1 receptor, and that's called PD-L1 or PD ligand 1. So you can see on the schema on the left, if the PD-L1 ligand is expressed on the surface of the tumor cell, that can then bind to the PD-1 receptor on the surface of the T cell, and whereas you might have otherwise gotten T cell killing of this tumor cell, that T cell is now no longer activated. And so others have looked at PD-L1 expression, and you can see PD-L1 expression on many, many different types of tumor cells. This is a PD-L1 expression shown in brown on immunohistochemistry in squamous cell head and neck cancer. It's also been shown extensively in melanoma, lung cancer, renal cancer. A lot of other types of cancers exploit this immune checkpoint as well. So then how do we take advantage of this? So once the PD-L1, PD-1 axis had been identified as a real important player in cancer and tumor immunology, immune checkpoint inhibitors or immune checkpoint blockade was developed. And this is really a class of drugs now that inhibit immune checkpoints on the surface of T cells. And inhibiting these negative regulators of T cell activity stimulates the recognition and killing of tumor cells, takes off the brakes that are inhibiting this T cell activity. And so specifically the first two inhibitory receptors that have been targeted by immune checkpoint inhibitors are these CTLA-4 and PD-1 receptors. There's a couple CTLA-4 inhibitors, ipilimumab and tremelimumab. There's a few PD-1 inhibitors, including nivolumab and pembrolizumab and cemiplimab. There are many others in development. And then there are also, so if you think back to that previous slide, there's the PD-L1 ligand that binds to the PD-1 receptor, and that's expressed on tumor cells and some immune cells as well. And so there have also been PD-L1 inhibitors that have been exploited therapeutically, and these include durvalumab, atezolizumab, avelumab, and also there are others in development as well. So I think it's important then to think about how immune checkpoint blockade works. Because there's a fundamental difference between immune checkpoint blockade and a lot of the other treatments that we think about, including chemotherapy, radiation therapy, targeted therapy. So in all of those other types of therapy, when you give chemotherapy or when a patient gets chemotherapy, as soon as the chemotherapy is kind of processed and metabolized by the body, by and large, the chemotherapy stops working. And radiation, the same thing. I mean, causes DNA damage that may cause cell death at later points in the cell cycle. But essentially, when you turn the beam off, the drug, or when you turn the infusion off, the drug stops. But with immune checkpoint blockade, it's something fundamentally different because you are actually leading your body's own immune system to work. And the T cells that you create or that you disinhibit with immune checkpoint blockade are the actual drugs that are mediating the tumor cell death. And why is that fundamentally different? Because while chemotherapy and targeted therapy and even radiation therapy have kind of a finite time limit over which they act in most cases, immunotherapy may not. Because these T cells, just like you might develop a memory T cell response when you're vaccinated as a child, you can also develop a memory T cell response that can be activated against cancer. And so that could explain why some of these cancer immunotherapies can potentially work for a really long period of time. So in terms of immune checkpoint blockade, CTLA-4 inhibitors were first approved in metastatic melanoma patients. They were the first drug to demonstrate a survival benefit in a randomized controlled trial in patients with metastatic melanoma. And then PD-1 and PD-L1 inhibitors were subsequently found to be effective across multiple different tumor types. So first in melanoma and then in many other tumor types as well. So if you just think about, where are we seeing PD-1 and PD-L1 inhibitors? These are probably, well known to anybody who sees patients. They're really everywhere now. In the United States, they're approved for the treatment of melanoma, lung cancer, kidney cancer, liver cancer, lymphoma, bladder cancer, head and neck cancer, Merkel cancer, stomach, skin cancer, cervical cancer. And then I just wanted to spend a second on these highly mutated cancers. So actually, PD-1 inhibition was the first cancer therapy to be approved based on a molecular phenotype. So patients with mismatch repair deficiency or deficiencies in repairing mutations or DNA damage, and not just in one cancer type, but across every different solid tumor that was refractory to primary systemic therapy. And that's a big deal because it's one of the first examples, or the first example, of hopefully what's going to be many more approvals in oncology for drugs that use a molecular phenotype across different types of tumors based on what we know works. And in the case of immune therapy or immune checkpoint blockade, these highly mutated cancers have they have more mutations than your average cancer. And if you think about what that means for the immune system, more mutations means more potential tumor antigens that can be recognized by the immune system. So it's not surprising that immune checkpoint blockade is particularly effective in these types of cancers. And I think these are not the end of the story. Actually, it's hard to keep this slide up to date. In the United States, I think the PD-1 inhibitors were also just approved for hepatocellular carcinoma, and their activity in other tumor types as well, including ovarian cancer, triple-negative breast cancer, and others. So there are probably more approvals coming in the future. And there are literally hundreds, if not thousands, of ongoing trials testing these immune checkpoint inhibitors alone or in combination across tumor types. If there's no other evidence about how much this has changed the landscape of oncology, their quarterly sales are in the multiple billions of dollars, US dollars, for the two most widely used PD-1 inhibitors, just for one quarter alone in 2017. And it probably continues to dramatically increase this year as well. So this truly represents a new pillar of cancer care. This was a AACR Cancer Progress Report published in 2015. And if you look at now the different types of different modalities of cancer treatments that we have to think about incorporating into treatment for our patients, surgery, radiation therapy, chemotherapy, more recently precision therapy, and now immunotherapy. So how do we think about incorporating these treatments together? And again, I want to go back to, what makes immunotherapy different? And so, what makes immune checkpoint blockade different, in contrast to chemotherapy, radiation, and targeted therapies to some extent, tumor cells are killed by the T cells that are disinhibited by immune checkpoint blockade. And again, these T cells can persist. So in contrast to most other therapies, immunotherapy can continue to work for long periods of time in patients with widely metastatic disease. So how does this translate into clinical outcomes? So if you look at the survival curves that have been seen or observed in patients treated with immune checkpoint blockade, in a lot of ways, these are fundamentally different than a lot of the other results that have been generated with other systemic therapies. So if you take immunotherapy on the left, you get this, what's been called a tail on the survival curve. So you take in untreated patients, you get the survival curve in red, you have few long-term survivors, and then if you treat patients with immunotherapy, there's a subset of these patients that develop these long-lived anti-tumor immune responses, and so you raise that survival curve, and you get these patients that are surviving years after initiating treatment. In the case of metastatic melanoma, which was again the first cancer for which immune checkpoint blockade was approved, there are now patients that have been initially treated with ipilimumab and subsequently PD-1 inhibitors these are patients with widely metastatic melanoma that are now out well over a decade, close to 2 decades or even longer. And so there's for the first time the potential really for a cure, or at least a very, very long-term remission in these patients with widely metastatic disease treated with immune therapy. And that's just, I think it's impossible to kind of to try to say how much of a paradigm shift this has been in oncology, because the potential for that really long-term benefit is really makes a very meaningful difference in the care of our patients. And it's very different from other therapies. So if you take targeted therapy, where a majority of patients may respond, what you see is something different when you look at the long-term survival curve. You see that there might be a larger percentage of patients that benefit in the short term, so you see a shifting of this blue survival curve over to the left. But if you actually look at the long-term results, 2, 3, and even more years afterwards, you see hardly any long-term survivors. Eventually, these patients almost uniformly become resistant to these types of therapy. So that's the good news. So we have these new effective therapies that work in many different types of cancers. But it's not all good news. There are significant limitations to these immunotherapies, and specifically to the immune checkpoint blockade. And so I think it's helpful to compare immunotherapy in the setting of cancer therapy with immune checkpoint inhibitors to the uses of immunotherapy in other settings, and particularly in infectious disease, because I think that's where we're all fundamentally most familiar with immune therapies, and that's largely in the form of vaccines. So on the left, you can see right after the approval of the initial polio vaccine, the lines of people waiting, blocks and blocks to get the polio vaccine. And it's not surprising, because the polio vaccine and other vaccines are effective in the vast majority of people who receive that type of immune therapy for infectious disease. So polio vaccine, for example, effective in 99% or so of all people who receive the vaccine. But that's very different when you start talking about cancer immunotherapy. So in the case of cancer immunotherapy and immune checkpoint blockade, while these drugs can be effective in some percentage of patients, actually it's the minority of patients. And so depending on what type of solid tumor, only about 0 to 40% of patients respond to cancer immunotherapy depending on the cancer type. And so why is this? I think there's a number of reasons, but one of the fundamental reasons, or one of the fundamental differences between cancer immunotherapy and the treatment of infectious diseases with immunotherapy is the large diversity of cancer cells. So if you take polio on the left, where you can largely treat this with a vaccine or prevent this with a vaccine, one polio virus looks very much like another polio virus. So not too much of a leap to imagine that you can generate an effective vaccine that prevents polio in most individuals. Cancer is not the same situation. There's a tremendous amount of heterogeneity. So there's heterogeneity between different cancer types. So obviously to the immune system, a breast cancer looks very different than a prostate cancer, looks very different than a colon cancer. Even within a single cancer type, one breast cancer in one individual looks very different to the immune system because of the different pattern of mutations than another breast cancer. And it gets even more tricky than that if you take heterogeneity that can even occur within a single individual. So an individual with widely metastatic cancer, for example, that's spread to multiple different places of the body. A cancer metastasis in one location has the potential, because of different mutations in a different immune microenvironment, to look different to the immune system than a metastasis in another location, which would make immune recognition and destruction even more challenging. So because only a minority of people respond to cancer immune therapy, it's useful to think about how we might improve the effectiveness of tumor immunotherapy, and particularly immune checkpoint blockade. So if you think about the first major limitation, you might have tumors that are not initially recognized by the immune system. And this is what you could also call a primary resistance to immune therapy. So they're treated with immune checkpoint blockade. The tumor continues to progress kind of unabated. And what's been discovered is, it's actually very tricky, not surprisingly, because of the complex T-cell biology, and that this initial anti-tumor immune response depends on a number of coordinated steps that's been kind of lumped together and called the tumor immunity cycle. So if you think about the tumor immunity cycle, you can think about the number of steps that have to happen before you can get an anti-tumor immune response. So you need these cancer cell antigens on the bottom left to be released. You need them to be presented by these antigen-presenting cells. You need the priming and activation of the T cells. This usually occurs in the tumor-draining lymph node. You need then these activated T cells to traffic back to tumor cells. You need the T cells to actually get into the tumor cells. And then you need them to recognize and actually kill the cancer cells themselves. And so if you think about how immune checkpoint blockade works, going back to my initial slides, you can see that really immune checkpoint blockade only deals, at least the current immune checkpoint inhibitors, only deal with a limited number of these steps in the tumor immunity cycle. So the CTLA-4 inhibitors particularly can help prime and activate T cells, and then PD-1 inhibitors and potentially CTLA-4 inhibitors as well can help deal with kind of these latter steps in the tumor immunity cycle where the tumors are inhibiting killing of the cancer cells through the presentation or expression of PD-L1 that binds to the PD-1 receptor. So we're left with kind of this deficiency here. So we have a number of tumors that may not be recognized initially by the immune system. And immune checkpoint blockade really doesn't deal with these initial two steps of antigen release and presentation. So if you think about an analogy for this, you have your current types of immune checkpoint blockade. We're getting sophisticated now about adding gasoline or taking off the brakes of the immune system, but we're still in the very early days of the caveman days of how do we generate this initial immune response? How do we get the immune system to recognize the cancer cells in the beginning? And there's been a lot of work working on this to try to develop ways, and one of the ways that in the lab has been shown to be able to recognize or to generate this spark and generate this initial immune recognition is targeted radiation. And the idea is that if you kill tumor cells, especially with higher doses of radiation, as I'll talk about in the second half, you get this tumor cell death. And the tumor cell death is not the same kind of tumor cell death that you might otherwise get. It's what's called immunologic cell death. So by killing cells with higher doses of radiation, you get release of these tumor antigens, and you also get these co-stimulatory or activating signals. So then these antigen-presenting cells are able to traffic to the tumor-draining lymph node. In the tumor-draining lymph node, they encounter these naive T cells, as I talked about in the beginning, and then because you have this setting of immunogenic cell death, you can activate these T cells, and these T cells can then traffic back and cause tumor cell death. And really, that's something that we might have been observing for a while without even knowing it. I mean, there's been this long-established phenomenon that's very rare in clinical practice, but has been observed in multiple tumor types. And this is, of course, the famous abscopal effect, where you can irradiate one site, and then without any systemic therapy, in very rare cases, you can see responses outside of the radiation treatment field. So this is, one example of an abscopal response that occurred at the Dana-Farber in a patient with Merkel cell cancer. So this patient had a number of their metastases treated on the upper part of the lower leg, circled in green, with a notable exception of the lesions circled in black. After radiation alone, so this patient received no systemic therapy, they had resolution of not just the treated lesions in the upper part of the lower leg, but also complete resolution of the lesion in the black circle. And so this is, further work has been done in other tumor types. This is probably happening via immunologic mechanisms, through the immunologic cell death that's shown on the left. And so you're left with a picture that now looks like this, where you have certain steps of the tumor immunity cycle that can be influenced by immune checkpoint blockade, but other parts of the tumor immune cycle that can be influenced by radiation to help address some of these deficiencies. And so this was also shown preclinically. This was kind of seminal work done now over a decade ago by Silvio Clemente and Sandra DeMaria in New York, looking at combining radiation and immune checkpoint blockade to generate this abscopal effect in the lab. And they did a series of experiments in mice where you inject tumors on one flank, you irradiate these tumors either with or without the addition of 9H10, which is an anti-CTLA-4 antibody that's active in mice. And then you look not just at the response of the primary tumor, but at an unirradiated secondary tumor on the opposite flank, and also the ability to improve survival in these mice. And if you actually look at the bottom survival curves, you can see that only the combination of radiation and immune checkpoint blockade is able to eradicate these out-of-field metastases and improve survival. And very recently, we're starting to see the hints that we may see the same effects under certain circumstances in patients. So this was a recent analysis done out of UCLA, looking at patients treated with immunotherapy on one of the initial Keynote protocols, which tests the PD-1 inhibitor pembrolizumab across multiple tumor types. This was an analysis done specifically in lung cancer patients. And what's really interesting about this analysis is if you actually look at the patients that had previously received radiation, shown in red, they had superior survival when treated with the immune checkpoint inhibitor as compared to patients who hadn't previously received radiation therapy, shown in blue. So I'll talk about more clinical data in the second half of the talk, but this is just one kind of piece of evidence that if you get the right circumstance, maybe you can help address the deficiency and increase the number of responding patients by using radiation therapy. Another potential issue that I alluded to previously is tumor heterogeneity. So if you generate this anti-tumor immune response that recognizes all of the different tumor clones except for one, that's not good enough to really affect a long-term benefit for patients. So if you have patients who are treated with immune therapy, you can have a mixed response to initial therapy. A lot of the metastases may respond, but then one or a few may not. Or there's also a pattern that's been increasingly appreciated, especially in melanoma and non-small cell lung cancer patients, but of acquired resistance. So you have patients who initially respond to immune checkpoint blockade and then progress. And so this progression can display in a lot of different ways, but there are an increasing number of patients, particularly as I mentioned with melanoma and non-small cell lung cancer, who can develop this isolated or oligo progression. And there might be a good biologic reason for this. So this is correlative data in some of these patients. Work is in non-small cell lung cancer patients. And on the left, you can see in a patient who initially responded to immune checkpoint blockade and then subsequently developed isolated or oligo progression, they had, when the T cells and the tumors were sequenced, they had a specific loss of tumor antigens that were being recognized by the immune system just in that metastasis that was then resistant to immune checkpoint blockade. So that clone had developed a way to evade an anti-tumor immune response. As I mentioned, there's also potential differences in the immune microenvironment. So this was another study in non-small cell lung cancer patients that looked at differences in the immune microenvironment in individual patients. So compared metastases in the lung, in this case, to metastases in the brain. And so if you think about the way that immune checkpoint blockade works, you need actually the immune cells to be there because you need them to be disinhibited. So in this example, what they saw with the green bands is there was a number of patients that had immune infiltration within the lung, but not in the brain. So you can imagine these patients might develop a mixed response where they respond in the lung to immune checkpoint blockade and then have these resistant metastases in the brain. And I think this is a bigger deal than people realize, because if you develop isolated or oligo progression on immune therapy, if you think about our standard practice in most cases, when a patient is progressing on systemic therapy, you switch to systemic therapy, especially in a patient with metastatic disease. In most cases, I mean, I think we're now treating more and more patients with oligo progression kind of across the board, but this has particular relevance in the case of immune therapy, because if you think back to the survival curve or in immune therapy, there are the potential for these patients to derive really long-term benefit with immune checkpoint blockade. So the opportunity cost of switching systemic therapies is potentially huge. And so we've actually started to look at this. So this is work that Andrew Bang, who's in the audience, and others have contributed to, looking at our series of melanoma, non-small cell lung cancer, and renal cell cancer patients. So these are patients who received PD-1 inhibitors prior to progression. If you look at the timeline plot on the left, you can see the time they were on PD-1 inhibitor was shown in blue. And then they developed this isolated or oligo progression. And instead of switching systemic therapy, we treated them with targeted radiation. And then what you can see in the red bars is these patients, to varying degrees, were able to remain on systemic immune checkpoint therapy. So instead of changing systemic therapy and giving them chemotherapy or targeted therapy, which would have probably only worked for a very short period of time, they stayed on immune checkpoint blockade. And there are some patients who then progressed relatively quickly, but if you look at the red bars, you can see there were some patients who remained on immune checkpoint blockade for really significant amounts of time. And so I think we just need to do a better job at identifying who those patients are going to be, and then we can more aggressively target these patients for local therapy like SBRT. And we're actually prospectively testing this strategy in squamous cell head and neck cancer patients using head and neck SBRT for patients who develop local recurrences who might have initially responded to immune therapy in combination with pembrolizumab. So that's two limitations. So I wanted to talk about one final limitation, and that's something that we all kind of fundamentally have an appreciation of, and that's cancer patients unfortunately have impaired immunity, and we're trying to treat them with immune-stimulating drugs. And this could be because of prior treatments we're given, so chemotherapy, large field radiation, which I'll talk more about, and then just advanced cancer alone is immune suppressive. And if you look at the ways that might happen, is that the tumor burden might impact your response to immune checkpoint blockade because this large burden of tumor cells can lead to increased number of regulatory T cells, other cytokines that help suppress the immune system. And also, if you think about how immune therapy works again, the kinetics of rapidly progressing disease can outpace the generation and activation of immune effector cells. And that's something we've actually looked at in the setting of head and neck cancer. This is work we did with patients treated with immune checkpoint blockade. And you can see if you divide them out by burden of disease as measured by RECIST, you can see that patients that have a total tumor burden that exceeds the median are less likely to derive clinical benefit, shown in gray on the left bar graphs, and then also have inferior survival. And actually, there are few, if any, long-term survivors among patients that have these tumor burdens that are above the median in patients with head and neck cancer in our series. And so this is actually a pattern that I would argue is seen more broadly across immunotherapy. We looked at some of the landmark immunotherapy trials. So a lot of the landmark immunotherapy trials are either called Checkmate or Keynote, based on what drug is used. And what you interestingly see if you look at the patterns of progression-free survival is you see a deviation from proportional hazards. And what does that mean? If you look at these initial parts of the survival curve, you basically see they overlap. So patients who progress quickly, who are in the initial kind of 50% of events, derive very little, if any, benefit from immune checkpoint blockade in these studies, and then you get this tail on the survival curve. And so if you think about why that might occur, so sorry for anybody who's still eating breakfast, but you have this large burden of tumor cells here, shown as ants in this picture, and then you're actually, again, you're activating the immune system, and you only have a limited number of T cells. So if you think about the T cells, even if they're really effective killers of the tumor cells, you're only limited in what you can do depending on how many T cells you're able to generate and the rapidity with which you're able to generate them. So if you add in then another treatment, so in this case radiation, there's some argument that you could use other treatments like chemotherapy for this as well, you're then left with a much more favorable situation, because if you decrease your tumor burden, then the immune therapy doesn't have to do quite as much heavy lifting. And if we think about this in the case of infectious disease, we do this all the time. We don't rely on our body's own immune system to treat a bacterial infection. We give it a little help with antibiotics first, and then we let the immune system eradicate kind of that minimal residual infection. And so potentially the same is true of cancer immune therapy as well. And so if you look at the clinical evidence now, so this is the landmark Pacific trial where immunotherapy was used in stage 3 non-small cell lung cancer. So this is a situation that's unique, right? Because the chemoradiation was given in this study to eradicate all areas of visible disease. So these patients received full course chemoradiation and then were randomized to PD-L1 inhibition with durvalumab versus placebo. And you see these really significant benefits in terms of progression-free survival with a hazard ratio of 0.3 and then overall survival with a hazard ratio of 0.68. And so this is significantly greater than you would see in an unselected metastatic population where response rates are generally 10 to 20%. And again, this might be because of the phenomenon that we're able to decrease the burden of immune suppressive disease. So the outstanding questions is, will this increased efficacy of immune therapy hold true as immunotherapy is explored with radiation in the localized or locally advanced settings? And I think intriguingly, can we meaningfully impact immune suppressive disease burden in the metastatic setting, for example, with SBRT? So to summarize, current immunotherapies predominantly act upon T cells, at least that's how we think they act, and only a minority of patients benefit. The addition of targeted radiation can potentially address both primary and secondary resistance. And then the optimal integration of radiation immune therapy requires more investigation. And here's where I think the tumor immune ecosystem comes in. So remember, as I mentioned in the beginning, we start with this tumor immunity cycle. But if you think about it a little bit more broadly, this tumor immunity cycle only applies to kind of this initial phase of immune activation and generation of an immune response in kind of one location in the body. But that's not really what we're trying to do for our patients. We're trying to eradicate all the disease in all the particular types and all the locations where patients might have metastases. And so we don't just care about the primary tumor. So the tumor immunity cycle is still very important. We still need this kind of microscopic generation of an immune response. All those steps that I talked about are still critical. But what we also need to address is these kind of macro effects, these tumor immune ecosystem effects. So do patients have, too inhibitory a tumor burden? Is their burden of disease going to preclude immune therapy from working? Do they have pockets that have developed isolated immune escape, whereas otherwise they're responding to immunotherapy? And finally, we need to think about how the different metastases are connected immunologically. And there's kind of intriguing work that I don't have time to talk about, that you can have these positive abscopal effects where you can irradiate one site and maybe have immune cells that traffic to another site, but you can also have negative effects as well. So if you use another treatment like surgery that doesn't just generate a hub of immunologic activity, but removes that hub, you can see that can cause a potential detriment in the overall anti-tumor immune response. So I think that there's a lot of opportunities for radiation here, for SBRT specifically. I'll talk soon about the clinical data, but this is, I think, a kind of a framework to understand the ways that radiation might impact immunotherapy and an anti-tumor immune response. So, thanks.